intervention and possibly treatment.
I don't think it's inevitable that it will get worse. It's unlikely that it's going to get better without any type of therapy, especially at that age. But if there's no evidence of any infection, and if there's no evidence of infection and a person has incontinence, I would recommend starting something like the exercises. I think that's a nice non-invasive way, something that you can do for yourself in the long run that will do yourself a lot of good. And again, it just depends on how much it bothers you. If it bothers you enough to think about it and to want to do something about it, I think that's the time to start treatment.
Dr. Stern, what do you tell women in your practice?
Right. I ask the question to almost every patient whether they leak urine when they cough or sneeze or leak urine unexpectedly. And many times patients say, oh, yeah, it's rare, but I do. And they don't see it as a problem. But in those patients, even in those patients, I do recommend Kegel exercises and estrogen therapy if they are not on estrogen, because certainly we want to improve that little bit if we can before it does worsen, if that's going to be the progression of things.
Yes, ma'am.
If one has had this stress incontinence for a while and over 70, would Kegels help, or is that just for the very mild cases, number one? And number two, are you familiar with these little weights that they I read about, that they insert increasingly heavier weights to work the muscles even more?
The question for anyone who didn't hear is, are Kegels effective for stress incontinence, and do weights, vaginal weights, help training for Kegels?
Again, I think that in any age, anybody with stress incontinence, when done with a regular regimen of Kegels and again some estrogen creams, I usually use them in conjunction, especially in someone who's postmenopausal who lacks estrogen. I think that a regimented routine actually will improve. Now, I'm not saying it will totally improve your situation, but it would probably help when done very regularly. I'm a little more, I usually tell patients 10 repetitions 10 times a day, whether it be when they're watching TV with commercials or something that may trigger their memory to do them. It's a difficult thing to remember, but if done very regularly, I think it does improve. And I'm sorry, what was the second part of the question?
Weights.
Oh, yeah, the weighted cones I have heard of. I don't have that much experience with them, but I think physical therapy uses them, and I think that they would definitely be helpful, especially with a physical therapist there working the muscles with you and the biofeedback in combination.
Dr. Barnes, I have a question for you. Have you ever seen a woman who's too old for pelvic floor muscle retraining? A lot of patients in their, usually late 80s come to see me and they say, I think it's helpless. There's no way that I'm going to learn how to squeeze that muscle. It's long gone.
I don't think that's that it's really long gone. I think it has more to do with the attitude and whether or not the patient is willing to do it and whether or not they can really remember to do them, and again, whether or not they're really motivated to do the procedure. If they're willing to do it and if they're motivated, I think they definitely most of the time can. And it's at least worth a shot in definitely having someone help them with the exercise, help them identify where the muscles are. And I think that's why the cones can be useful. I don't have a whole lot of experience with them either, but I think the cone is just another way of isolating the muscles that you're trying to use. It's just another way, whether it be with a little electricity or with a cone or something in the vagina. It's just another way to isolate the muscles that you're trying to use. So I think that's the reason they are.
Yes.
Does transvaginal surgery have a long-lasting effect, or is it something that's going to require continuous surgery over a small amount of years? Or
we tell people that it's supposed to be a permanent solution. It's the same.
It depends on which vaginal surgery you have. I think as a gynecologist, I'm sorry, I didn't mean to interrupt, but anterior colporrhaphy, just replacing the bladder into its position, is now found not to actually be the treatment of choice for true incontinence. So urologic slings and things are, as she was saying, supposed to be more permanent.
Pubovaginal slings and the open procedures are supposed to have the same success rate for the same amount of years. So I tell people that routine pubovaginal slings have an 80 to 85% success rate at 5 to 10 years of being either completely dry or very near dry, 80 to 85%. And it's the same with the birch procedures or the open procedures. We tell them about the same thing. And the nice thing about transvaginal surgery